Hello and welcome. Today we'll be diving into a fascinating and sometimes frustrating kidney condition called minimal change disease. It's a leading cause of nephrotic syndrome, especially in children, and understanding it is key to effective management. Let's unravel the mysteries of minimal change disease. So, what causes minimal change disease? The honest answer is, we're not entirely sure in most cases. It's usually idiopathic, meaning the cause is unknown. However, certain factors are thought to potentially trigger it in some individuals. These include upper respiratory infections, vaccinations, non-steroidal anti-inflammatory drugs and NSAIDs, and even Hodgkin's lymphoma in rare cases. The exact link between these triggers and the disease onset is still being actively researched. Now let's delve into the pathophysiology, or how this disease actually works. In minimal change disease, the kidneys glomeruli, which are responsible for filtering blood, appear almost entirely normal under a standard microscope. Hence the name, minimal change. However, electron microscopy reveals a crucial abnormality: effacement, or flattening, of the podocyte foot processes. Podocytes are specialized cells that act like a final filter layer in the glomerulus. When these foot processes are flattened, the filtration barrier becomes leaky, allowing large amounts of protein, particularly albumin, to escape into the urine. This massive protein loss leads to the hallmark symptoms of nephrotic syndrome. In terms of epidemiology, minimal change disease is the most common cause of nephrotic syndrome in children, accounting for about 80–90% of cases in this age group. While it can occur in adults, it's less prevalent, representing approximately 15% of adult nephrotic syndrome cases. There appears to be a slight male predominance in childhood cases. Overall, the incidence is estimated to be around 2 to 7 new cases per 100,000 children per year. The signs and symptoms of minimal change disease are primarily those of nephrotic syndrome. The most prominent symptom is edema, or swelling, particularly in the ankles, feet, around the eyes, and sometimes even generalized swelling known as anasarca. Patients also experience heavy proteinuria, meaning a large amount of protein in the urine, often discovered during routine urine tests or when noticing foamy urine. Low levels of albumin in the blood, called hypoalbuminemia, is another key finding. High cholesterol and triglycerides, or hyperlipidemia, are also common features. Some patients may experience fatigue, loss of appetite, and abdominal pain. Diagnosis of minimal change disease typically involves a combination of clinical findings and laboratory tests. A urine dipstick or 24-hour urine collection, the presence and quantity of proteinuria. Blood tests will reveal low albumin levels and elevated cholesterol. However, the definitive diagnosis often requires a kidney biopsy. While the glomeruli appear normal under light microscopy, electron microscopy will show the characteristic podocyte foot process effacement. Immunofluorescence studies are usually negative, further supporting the diagnosis of minimal change disease. Minimal change disease doesn't really have distinct subtypes in the same way some other kidney diseases do. It's largely defined by its characteristic appearance under the microscope. We do, however, classify cases based on their response to treatment, as some patients may experience frequent relapses or become steroid-resistant, requiring different management strategies. The cornerstone of treatment for minimal change disease is corticosteroids, such as prednisone. These medications work by suppressing the immune system, which is believed to be involved in the underlying pathophysiology. Typically, a high dose of corticosteroids is given initially, followed by a tapering schedule to minimize side effects. In most cases, patients respond very well to steroid therapy, with proteinuria resolving within a few weeks. For patients who relapse frequently or are steroid-resistant, other immunosuppressants, such as cyclosporin, tacrolimus, mycophenolate mofetil, or rituximab may be used. Supportive care, including diuretics to manage edema, and AC inhibitors or ARBs to reduce proteinuria, are also important. Unfortunately, there's no known way to definitively prevent minimal change disease, given that the exact cause is usually unknown. However, avoiding potential triggers where possible, such as unnecessary NSAID use, and ensuring prompt treatment of infections, may potentially reduce the risk in susceptible individuals. Staying healthy and following a balanced diet are generally good practices to support kidney health. The prognosis for minimal change disease is generally excellent, especially in children. Most patients respond well to corticosteroid therapy and achieve complete remission. However, relapses are common, occurring in up to 80% of children. With each relapse managed appropriately, most patients eventually outgrow the condition. In adults, the response to treatment may be less predictable, and the risk of complications, such as infections and blood clots, is higher. Research continues to explore the underlying immune mechanisms of minimal change disease, with the hope of developing more targeted and effective therapies with fewer side effects. Current research areas include investigating the role of specific immune cells and cytokines in the pathogenesis of the disease. Newer therapies targeting these specific immune pathways are also being explored in clinical trials. These advances hold promise for improving the long-term outcomes for individuals with minimal change disease.